Well, good morning, everyone. Welcome to the Brunswick Downtown Association Speaking Events Series. My name is Deborah King, and I'm the Executive Director of the BDA. So every year, we typically host 3 of these speaking events live. But as you all know, this year is nothing like we've ever experienced before. So thank goodness for the power of technology. We are able to host these events only through the generosity of the community and the support of our sponsors, Riley Insurance, Sunnybrook, Avita of Brunswick, Atlantic Federal Credit Union, Mid Coast Parkview Health, and Bowdoin College. Your support enables the BDA to continue with programs such as these, as well as the many events and activities we host throughout the year. You can support the BDA by making a donation on our website by clicking on the Support Us button on our homepage. The topic of today's webinar is Local Insights to COVID-19, and we are so pleased to have such a highly esteemed panel featuring Dr. Nirav Shah to address the many issues surrounding the pandemic. Thank you to everyone who submitted questions with their registration. And if you have a question to ask today, please use the question and answer feature at the bottom of your screen, not the chat room feature. It is now my pleasure to introduce this morning's moderator and one of the panelists, Lois Skillings, President, Mid Coast Parkview Health in beautiful Brunswick, Maine. At Mid Coast Parkview Health, Lois leads the organization's senior executive team and is responsible for the strategic and operational performance of the health system, which includes Mid Coast Hospital, Mid Coast Senior Health, and Chan's Home Health and Hospice. Lois has been with Mid Coast Parkview Health for 40 years. Prior to being named president, she was vice president of nursing and patient services, responsible for patient safety and quality across the organization. Welcome, Lois.
Thank you so much, Deb. And thanks to all of you who are here today. I don't know if you can hear me or not.
Yes.
Yeah, good. Okay, great. So Mid Coast Parkview Health is just delighted to participate in this important event this morning. We're so proud to be part of the Brunswick Downtown Association, and we're also so grateful to the team of volunteers who put this program together. It's an honor for Dr. Chris Bowe and I to be part of your panel today. Dr. Bowe is the Chief Medical Officer and Vice President for Medical Administration for Mid Coast Parkview Health. And he earned his undergraduate degree from the University of Wisconsin, followed by his medical degree from University of Wisconsin Medical School, and completed his residency in emergency medicine at Maine Medical Center. He also there attended a physician leadership program and also is a graduate of the Daniel Hanley Center for Healthcare Leadership's Physician Executive Leadership Institute. And as the Chief Medical Officer, Dr. Bowe provides strategic and operational executive medical leadership and ensures the quality of care here at Mid Coast Hospital. And what an honor today to have Dr. Nirav Shah with us this morning as our featured speaker. For so many of us, Dr. Shah, you've been a beacon of truth and guidance since this pandemic began for both healthcare providers and the public alike. And the state of Maine is so fortunate to have your leadership and expertise during this challenging time. Some background about Dr. Shah: in June of 2019, Dr. Shah was appointed as the director of the Maine Center for Disease Control and Prevention here. And he came to Maine with broad experience in public health, most recently as director of the Illinois Department of Public Health, where he implemented key initiatives to address the state's opioid crisis, reduce maternal and fetal mortality, and reduce childhood lead poisoning. As an attorney and public health economist, as well as a physician, Dr. Shah previously advised professionals and governments around the nation and globe on improving the delivery of health care. And earlier in his career, he worked for the Ministry of Health in Cambodia, where he worked including investigating and managing disease outbreaks as an epidemiologist. He also received his medical and law degrees from the University of Chicago and studied economics at Oxford University. So thank you so much, Dr. Shah, for being here. We're very excited to have you with us and so look forward to learning from you this morning.
Well, thank you. It's such a delight to be here and talk to folks here in my new hometown, and I'm looking forward to taking and going through as many questions as we can this morning.
So now we're going to hear your remarks about what it is that if you would share with us the journey that we've been through here in the state of Maine, your perspective on how far we have come, and your assessment of what's ahead. We'd love to just hear from you this morning.
Sure. So let's start with, let's start where we should, which is at the beginning. About now 10 months ago, owing to work that Lois referenced that I did back in Southeast Asia 20 years ago, I happened to remain connected to many of the infectious disease epidemiologists that I worked with back in Southeast Asia, across Asia from that time period. And back in mid-December of 2019, I started seeing on some of the email listservs that I still happen to be a member of, discussions about cases of pneumonia in and around central China that didn't seem to have any connection to any known pathogen at that time, viral or bacterial. Now, for context, these sorts of things happen just about every week. But what was notable about this situation is that it didn't stop. And by Christmas, there were repeated reports coming across these various listservs that were starting to get picked up in the media in and around China about an increase of pneumonias of unknown origin. Between the period of Christmas and New Year's, I started corresponding with my staff. Of course, we were all scattered and with our families, but sending them some of these reports just for their awareness to see what we might be dealing with in the event that something of this sort were to become a proper outbreak, let alone what we now know it to be. A lot of that changed right before New Year's Eve, when the Chinese government officially notified the World Health Organization that something was going on. That was a signal to many of us in the global healthcare community that something quite serious was brewing. Generally, governments of that sort are reluctant to make large-scale public notifications of what's going on. The fact that they did just a week and a half after first detecting what was happening was of significance. So as soon as my team and I reconvened back in Augusta after the New Year break, we started sitting down to figure out what was happening and what we were potentially dealing with. Of course, at that time, we didn't know what we were dealing with was viral. We didn't know whether it was what family of viruses it came from and what the potential fatality rate, let alone the transmissibility of that virus might be. By mid-January, by January 11th to be exact, we had gone from not quite knowing what we were dealing with to recognizing that it was in fact a viral pneumonia, and they had actually at that time sequenced the entire genome, the entire genetic structure of the virus itself. A remarkable feat in about 8 or 9 days to go from not knowing what we're dealing with to isolating what was causing it and sequencing the entire genome. That rapid work is actually what has allowed the kickstarting of so many of the vaccines that I'm sure we'll talk about. But on a local level, it also meant that we were able to start beginning our preparations in earnest, which we did in early January. We started thinking about what our PPE supplies were, what our workforce would look like, what impacts that we might need to think about in places like shelters for people experiencing homelessness, the jails, and now, of course, as we're contending with the reopening with schools. That was why back in early January, mid-January, I formed a group within Maine CDC and started inviting representatives from other departments to join the conversation with what we could start to see. Fortunately, a lot of that advanced planning paid off. For example, we made early investments in PPE before other states were able to, which meant that our supplies were more robust after cases first started happening. That's just one example where early preparation, advanced preparation is something that paid off here in Maine. Of course, what we now know to be that early preparation resulted in a long and large-scale activation where Maine CDC and a number of other state agencies and departments have since that time pretty much been working 24 hours a day, 7 days a week, whether it's the Emergency Management Agency, whether it is the Division of Emergency Medical Services, you name it. We've all been pretty much joined at the hip since late January, early February, working on all things COVID. Since that time, there have now been just over 4,900 cases of COVID-19 across the state, innumerable outbreaks in every type of setting you can imagine, be it a long-term care facility, a school, at a college or university, workplaces. If it's a place where people can gather for a period of time, it's something that can generate an outbreak situation. And we've seen them across Maine as we've seen across the country. Quite sadly, 137 individuals have passed away with COVID-19 since the first case was identified on March 12th here in our state. And sadly, as we also think about the future, well, it's going to be tough. That's the bottom line. Just in the recent weeks, the number of new cases in Maine has increased. The complexion and the nature of outbreaks that we've seen across the state has been one that has caused concern among my staff as well as among myself personally, because what we're seeing are outbreaks as well as cases in parts of the state that didn't previously have them. So paper mills in Oxford County, school systems in Androscoggin County, and to say nothing of outbreaks elsewhere across the state that may be smaller and percolating that could generate more cases. The reason that is concerning, apart from, of course, but recognizing the very human toll that those outbreaks can have, is that the strength of our efforts to keep a lid on COVID-19 as we go into the winter, those efforts are directly tied to the baseline number of cases that we have going into those winter months. Winter is concerning for a number of reasons, fall and winter. One of which is that from a behavioral perspective, folks are more likely to be inside than outside, and thus we lose the protective effect of being outdoors. Individuals are still likely to congregate, but they're likely to do so inside rather than outside. So right off the bat, winter raises concerns. But we also have to contend with the co-occurrence of seasonal influenza, which is also coming our way very, very quickly. Now, it's impossible to speculate about what the magnitude of this year's influenza virus may be, but it doesn't matter, because even in a mild year, influenza is a very deadly virus unto itself. When you overlay influenza on top of COVID-19, you have a situation where you have an acute event on top of another acute event, influenza on top of COVID-19. In a state like Maine, that could be potentially significant in every sense of the word. So again, I'm sure we'll have a lot of questions as we start thinking about things like vaccination and other things, but certainly one of my key messages today is going to be make sure you have made your plans to get your flu shot as soon as your healthcare provider tells you it is appropriate to do so, or failing that, as soon as you can in the near future. What we don't want to happen is a situation where the healthcare system, physicians' offices, healthcare providers are overburdened with both COVID-19 as well as influenza. If we can keep flu rates low, that frees up all of those resources to contend with folks who have got COVID-19. And you can do your part in that respect by making sure you've got your flu shot as soon as it is available and ready to go. So with that, I am going to pause, and maybe Lois, I'll turn it back to you to see what direction you want to go from here.
Great, thank you, Dr. Shah. Some of the questions that we've had is around timing of the flu shots. You just mentioned the flu shot vaccine. People are wondering, what is the ideal time to get a flu shot this fall, and from a public health perspective?
everyone wants to time it just right, and here's the bottom line there: the best time to get the flu shot is when it is widely available, or when your healthcare provider says, "Hey, I'm giving you your flu shot today." Uh, our office gets a lot of questions about, should I wait an extra week so that I can get this, or extend the immunity a little bit longer? And uh, it's similar to trying to time other areas of life. The best time to get it is when it's available and when your healthcare provider says, today's the day we're giving it to you. If you don't happen to be in your doctor's office or your nurse practitioner's office, the best time to get the flu shot is when you're out running an errand, or you happen to be at a pharmacy or at the grocery store, and they've got it and it's ready to go. That's the best time to get it.
That's really helpful. The other questions that we received, and we have one even this morning, is people are beginning to wonder, how do we transition from the late spring and summer and early fall into winter with safe indoor activities? There's questions from the faith community. Some have held outdoor, indoor worship with risk reductions followed. What are the most important things for us to consider as we move into the fall season and toward the holiday season around being inside at either at restaurants or faith community or other places where people are gathering? And can you provide some guidance for that?
Yeah, Lois, this has been on my mind a lot as I think about my own family. One of the interesting findings scientifically about COVID-19, as well as a number of other respiratory viruses, not unique to COVID-19 specifically, but with respiratory viruses in general, there's a protective effect of being outdoors. That actually applies to respiratory bacteria, tuberculosis, and a number of diseases. And that protective effect comes from different pathways. In some respects, it's related to the presence of ultraviolet light. In some respects, it's related to better ventilation when you're outdoors. We won't get into that. But clearly, as we move indoors in the colder months, the risk of COVID-19 transmission goes up. That's unfortunate, but we got to be straight with everybody. Indoor activity raises the risk of COVID-19 transmission. So let's talk about your home first. You've got the most control over things at home. And so when you're talking about having folks over on a Sunday for Sunday dinner, I think we've got to be, I hate to say it, but I think we've got to be careful about those things. If they're not folks that you know who have been separately taking precautions, it's going to be a risk. Things like worship services also been something that's on my mind. I've had the pleasure of speaking with one or two members of the faith leadership community across Maine in the past week about this exact issue as we go into the fall and the winter. The guideline that we have offered is for there to be no more than 50 individuals indoors at any one time as part of a gathering. But the honest answer is that is an approach that doesn't necessarily take into account the nuances of different types of buildings. So in a small church with limited ventilation and limited air filtration, 50 may be too large of a number. If individuals are packed close together, and let's face it, when you go to church or a house of worship, you're not there to be alone for the most part. You're there for fellowship. You're there to hug folks and sing and share in that celebration. Unfortunately, those are the same types of things that can generate transmission of the virus, being in close proximity, things of that nature. So even in a house of worship, even though it may look out of sorts, wearing a face covering is a great way to reduce the risk if you're in a place that doesn't have great ventilation, that doesn't have great air filtration. Wearing a face covering indoors is a step that you can take to reduce your risk of infecting others. One of the things that is insidious about COVID-19 is that it takes advantage of the things that make us not just human, but that make us a community. It takes advantage of the fact that we like to gather in groups. It takes advantage of the fact that when we are in those groups, we like to do things like talk loudly with one another, if you're in my family, or sing, or be close to one another and embrace one another. Those are the things that make human life what it is, that make community life vibrant and worth living. But they're also simultaneously the same things that generate transmission of the virus. That is, I think, one of the most sorrowful aspects of COVID-19. It doesn't prey on somebody who lives by themselves in the woods 11 and a half months out of the year. It looks for opportunities where individuals are together, celebrating, and often when those individuals are older and more vulnerable. So we've got to keep that in mind as we go into the winter, keeping distance even when you're indoors, working to wear masks when you're indoors are ways to reduce that risk.
Thank you, Dr. Shah. You know, another question is, how are faith communities monitored for compliance with the risk mandate and social distancing and masking? And it kind of leads over into other entities as well, whether it be grocery stores or others. How are ways that we as a society and a community can help to promote and ensure that these recommended guidelines are being upheld?
The best thing we can do is make sure that each and every one of us is doing our part. So generally speaking, the best way to get toward compliance with any norm is to make sure that that rule, that recommendation is the baseline. That is to say that whatever we're talking about is the thing that everyone expects. Whether it's wearing a seatbelt, driving the speed limit, wearing a bicycle helmet, or in this case, wearing a face covering when you happen to be at the grocery store. Making those behaviors the baseline norm societally is one of the best ways to ensure compliance. That is to say, just making it the expectation. Now, that gets us a large measure of the way there, whether it's with bike helmets or seat belts, or in this case, face coverings. That in and of itself gets us a large measure, but it's not the entire way. So then there are other mechanisms for enforcement, but they should be the last step, not the first step. The number of emails that we get saying you need to shut down this restaurant or you need to shut down these 12 grocery stores is quite remarkable, and it's not the right order of operations. The right order of operations is for individuals themselves to make sure that they are setting the norm. And by individuals here, I mean the managers of these stores, things of that nature. So even those of us who are fastidious about wearing a mask, if we are in somewhere where mask wearing is not the norm, one of the first things we can do is to speak with the management of that organization to say, hey, you know, I'm disappointed in what I'm seeing today. The governor's executive order empowers you to bar entry to those who are not wearing face coverings. I'd like to see you do more about that. I think we have hard questions to ask about whether we want, how we want enforcement to function as a society in this respect.
That's a really great segue to a great question from one of our town councilors that's asking that some constituents are reacting to what's been happening in Sanford, and in response to increases in outbreaks there, their local government unanimously passed its own mask ordinance. We have one here in Brunswick, but have had some ask that we do the same here that's even stronger. What would be the difference between anything local we could do and what's already in place at the state level? Do you have any advice for local policymakers?
Sure. You know, the two are not mutually exclusive. Indeed, they are coextensive with one another. In the governor's executive order, she empowers towns, cities, municipalities to separately and independently enforce what is in her executive order, as well as to take steps on their own, as you noted, Lois, as Brunswick has already been a leader in doing. There are, of course, ways to ratchet it up. I don't have a position on those, but we ought to always think about when we're ratcheting things up, what will come next? Will there be an enforcement mechanism around that? And what else is on the table that we might want to think about? Right now, mask wearing is a requirement in and around Brunswick, and that's a good thing. If we make mask wearing a requirement, for example, when you're out walking on the street by yourself, is that something where there's a risk of COVID-19 transmission that we ought to be addressing? So I think those are the hard questions. In so much of regulation, the first 85% or so is pretty straightforward. And that will cover most of the tough situations, but not all of them. And where you go for that last 10, 15%, that's really where the challenge is. Let's bear in mind that 6 months or 8 months after seatbelts were introduced, I'm going to venture a guess that seatbelt usage on month 8 after seatbelts were introduced was nowhere near what it is today, 40 or 50 years later. So the idea that mask wearing will be automatically overnight a universal norm, I don't think properly takes into account human behavior. So the question there is whether we use a series of incentives and social norms, or whether we make it something that is a punitive approach. Probably it's going to be a mixture of both. But what that balance is between making something a social norm and incentives versus a stick approach, that is really the difficult question when we think about governance or regulation.
Thank you, Dr. Shah. There's some very practical questions about, is it okay if I am outside with my family and friends in our yard and we're all more than 6 feet apart to take our masks off? Do I need to wear gloves when I go to the grocery store? How do I know that it is safe to go into a restaurant to eat inside? You may have already touched on that one. But the outside masking safety question and the wearing of gloves are things that I know we hear asked a lot, and they were questions that we got in advance. I wondered if you'd give some practical solutions.
Sure, Lois. Let's touch on the gloves one first. This is one that I've has come to me on a number of occasions, and I want to really touch on this one first and make sure I'm answering it completely. Early on in COVID-19, and honestly still to this day, there were concerns raised about the extent to which COVID could live on and be transmitted from surfaces to surfaces. There were some very early studies that suggested it could live on a surface for a number of hours, if not longer. Those early studies, I don't think provided the full context around what it means for a virus to live on a surface. A virus is just a series of genetic particles. It's not even clear whether viruses are alive or not to begin with. The question is whether the genetic material on the surface is one that is capable of being ingested and causing COVID-19. And that depends on things like the dose and a number of other things. But some of these early studies, as well as our totally understandable fear of the unknown back in March, April, generated this concern that the virus is living on all of the surfaces around us, and it could be a source of disease transmission. Since then, I'm not aware of any outbreaks or large-scale transmissions that have been traced to viruses on surfaces. So if you wear gloves when you are out and about, and that makes you feel safer, I understand that. But if you wear gloves, but you are saying to yourself, gosh, I wish I could take these things off because they're irritating my skin, you should also feel free to do that too. There is virtually no evidence to suggest that in large measure, COVID-19 has been transmitted and generated outbreaks from surfaces to surfaces. The same applies to things like wiping down all of your groceries when you get back. If that makes you feel safer, there's value in that. But if you say to yourself, boy, I really wish, I can't wait for the day that I stop spending 2 hours after every trip to the grocery store wiping everything down, you can probably pull that back now. The reason that's important is what I've seen, and I've seen it firsthand and heard it from a number of folks. We have limited time in our lives, in our days, and in our brains to focus on protecting ourselves against COVID-19. Our brain can only do so much. And if you were to come to me and say, hey, Nirav, I've got 2 hours of brain power dedicated to COVID-19 per day to protect myself, should I spend that time focused on wiping down my groceries or making sure that everyone I interact with has a mask on? The answer is clear. You should focus your limited time on things like masking and physical distancing as opposed to surfaces. So Lois, that takes me to the first question you raised, which is, what are the best practices if you're hanging out in your backyard? The best practice is to wear a face covering. That's the easy answer. Even if you can be 6 feet apart, you may not always be able to be 6 feet apart. So the best thing to do is to wear a face covering. Is it essential if you happen to be hanging out with your neighbors in a backyard where everyone is 10 feet away and it's sunny and the wind is blowing? Is it essential? No. It's not as critical as, say, wearing a mask if you happen to be at the grocery store or happen to be in church next to somebody. It's more essential there. But the question is, should I? The answer is yes. Is it essential? No. But is it safe? Is it protective? Sure. Do I get bent out of shape if I'm walking in the backyard and I see my neighbors and they come over and we're 10 feet away, but we don't have a mask on? I don't get bent out of shape about that. But again, it goes back to where we should be focusing our efforts. In this setting, it's really more about those close distances, like being in churches, being at the grocery store.
What about biking and running and masking when people are exercising outside?
Yep, give me about 4 seconds. I'm going to plug my computer in really quickly.
Okay. Well, and thank you all for being here with us this morning while Dr. Shah plugs his computer in. We have 364 people on this, 264 people on this call, and it's just wonderful to see this kind of interest in this from our local community. So grateful that you're all here with us today. You know, what we'll do is take a minute and talk about, there were some questions about Mid Coast Hospital and how did we ramp up so quickly? When did planning begin? And how do we implement the protocol so quickly? I would say that we started monitoring this also in January, and by February had activated teams to begin to plan for retooling our operations should worldwide spread begin. But in earnest, the beginning of March, it was very much in earnest. The beginning of March, standing up emergency preparedness systems, and really, when you ask how we ramped up so quickly, I would say it was the amazing team, the frontline staff, the doctors and nurses, and the people who just rolled up their sleeves, and the leaders who made it happen. And the other question about this is, what's been the most challenging aspect of this locally? I would say those first 6 weeks were among the most challenging that any of us have ever experienced. And it was really because we were watching what was happening in Boston and New York, and so afraid that that could happen here in Maine. And the quick response of our state CDC and state and local government to take matters into our own hands, to begin to really emphasize issues around social distancing, staying at home, exquisite hand hygiene, and then ultimately near the end of March, early April, universal masking or face coverings really made a big difference. And we could feel everybody's anxiety level come down as we saw the curve start to bend in Maine. But I would say that the question of what's been the most challenging aspect locally was those early weeks when I was afraid that we were going to have doctors and nurses and other healthcare professionals die of this disease, as we were seeing happening in Boston and New York, Chicago and Washington State and across the world. And I was also very much afraid that we would not have adequate personal protective equipment. The worldwide supply chain really shut down early on, and we started to see shortages. Thankfully, because we're part of the Maine health system, we were able to procure adequate supplies and even share those supplies with some of our local EMS and other nonprofit organizations in our community. So we feel like we were very fortunate to be here in Maine. So I see Dr. Shah is back, and we're going to switch over to ask him about the vaccine, to ask about the COVID vaccine and what you're hearing about this, what you think about this, and how we'll decide which vaccine we should have, and is there going to be more than one, and will you have advice after vaccines are available?
Mm-hmm. So let me first start by saying we do not know when any vaccine may be fully made and available and fully approved. And by we, I mean literally no one in the scientific or governmental or regulatory community. It depends on a number of players. It depends on independent scientists who are running the studies, the companies that are working to oversee those, and work with distributors to ramp up production of the vaccine. It depends on scientists at the FDA who will review the data, and it depends on state officials like me who will be then taking those vaccines and then working to administer them. All of those pieces are necessary in order for vaccine to be rolled out and administered. And when that process happens, which of course is the central question on everyone's mind right now, including mine, is right now unknown. Everyone's got their own view about when it might happen and so on and so forth, but the bottom line is that no one really knows. Because it depends on what the data are. It's not that there's a nebulous cabal of individuals who will go into a room one day and decide when this happens. It really does depend on what the strength of the data are, and that the way the trials are being structured, they're being structured from an event-driven perspective rather than a time-driven perspective. So the trials could take 6 weeks, they could take 6 months, based on the number of events that are generated. So there are very specific parameters that will have to be met before we have a sense of what even the data are, let alone what the regulatory response to the virus will be, to the vaccines will be. All of that is to say, right now there are a number of candidate vaccines that are in varying stages of study, development, approval, et cetera. Some of them are further along than others. And so as a result of that, it is likely that whenever vaccines are ready to go, we will have multiple vaccines on the table, not just one. Now, the differences between those vaccines will be what is critical to healthcare providers deciding which individuals will receive one type versus another. One may be more efficacious in younger individuals. Another may be more efficacious in older folks. We won't know until all the data are in. But it is probable, not a certainty, but it is probable that there will actually be multiple vaccines for COVID-19. But that assumes that all of the candidate vaccines actually make it all the way through the vaccine study process. And that's an unknown scientifically. So then the question is, what happens when the vaccines are ready? On day one, when the first vaccine is approved by the US FDA, it is unlikely that there will be enough vaccine out there to satisfy the demand of every single person who would like to have it. That's just an unfortunate fact. Now, the way that vaccines are being addressed right now is that there are actually vaccines that are being made as we speak right now. They haven't even been approved yet, but they're already being manufactured. So we hope that on the day that the vaccines actually get approval, that there will be a higher than anticipated dose were it not for that pre-making process. But all that being said, at a national level, there are already conversations happening around who should be in line to receive the vaccines first and who should be later down that line. There have been no decisions that have been made around that. But there are discussions around, for example, should first responders and ICU nurses and ER nurses be at the top of the line, or should school children and teachers be at the top of the line? Maybe nursing home residents and nursing home employees should be at the top of the line. Those are going to be very, very difficult decisions and discussions. No decisions have been made at the national level, certainly not at the state level, but I think that's going to be a conversation that the entire country is going to be having in great detail over the next several weeks and months.
That's great, Dr. Shah. Thank you. In the time we have left, we want to focus the next maybe 5 minutes or so on some travel questions. And then I'd like to move to testing and have Dr. Bowe jump in with you on some of the testing questions. So the testing questions are I'd like to talk about travel. So folks have been asking both beforehand, we had about 60 questions. A lot of them were related to travel. The guidelines seem to be focused on visitors who are coming to hotels and campgrounds, but what about guidelines for people who are out-of-state family members visiting Maine family members? And especially if they come by airplane and they test negative before their flight, should they test again once they get here and quarantining? And your advice about traveling right now?
So the guidelines in the executive order applies to anyone coming to Maine from other than 5 states. Whether they happen to be staying at a hotel, a campground, an Airbnb, it's not where they're staying that matters, it's where they are coming from. And unless you're coming from Connecticut, Vermont, New Jersey, New Hampshire, and New York, you've got to get a test within 72 hours before arrival. So then there are nuanced questions such as the one that you raised. So if someone is not staying at a hotel, they're a family member who's coming to visit, the answer is yes, they should get a test. If they're flying in as opposed to driving in, what is the risk of acquiring COVID-19 during travel on a plane? That risk is not well characterized. There are reasons to suspect that it's not as high as folks may have initially thought. Now, certainly being seated right next to somebody with COVID-19, that's a risk. That is similar to the house of worship scenario that we talked about. All the more reason to make sure you are wearing a mask in situations like that. But the planes themselves have good filtration systems, et cetera. So there's not the high risk from flying, but it is definitely a risk. Whether an individual should be retested upon their arrival, that's a question. And it depends on who they are. If they are someone who is older, medically vulnerable, it may not be a bad idea. Certainly if they develop symptoms after they arrive in Maine, after air travel, that's an indication to test. I don't think there's a bright line rule though, because it does depend on the individual, their risk profile, and who they're interacting with. If an individual is flying into Maine and they may be healthy, but they're coming to visit their immunocompromised mother and father, that's a different situation. And that's a situation where retesting might be indicated. So there's not a one-size-fits-all answer there, but certainly they need to be tested before they come into the state.
And certainly, Dr. Shah, we see the same thing happen here, that we sometimes feel that testing it's a very important and part of this tools for helping us to fight this pandemic. And at the same time, we want people to know that they should not have a false sense of security about a negative test, because it may be negative today and they may have symptoms that arrive tomorrow. Can you talk about that a little bit?
So the virus is one that needs to replicate inside the body in order for it to be detected by the tests that we have. And it can take anywhere from 1 day up to 5, in some cases 6 or 7 days, for the virus to have replicated enough so that the diagnostic tests that we use can pick up enough of the genetic particles in order to see that the virus is there. As a result of that, if you test somebody, hypothetically speaking, let's say person A and person B interacted with each other right now, and person A has got COVID-19, and they just interacted 4 seconds ago. If I tested person B, they wouldn't be positive yet because the virus hasn't had enough time to replicate and grow inside of them. So it does take some time for the virus to get to that level. And that's why a negative test doesn't mean you will never have COVID. It just means you did not have COVID at the time you were tested. That's actually the reason why, if you've been exposed to somebody who has COVID-19, maybe you're a healthcare worker and you took care of a COVID-19 positive person. Maybe you interacted with them at a lunch meeting. You will have to be in quarantine for 2 weeks. We get a lot of phone calls from folks who say, yeah, I had dinner with someone who had COVID-19. I got the call from Maine CDC, but I went and got tested and I'm negative, so I'm good, right? Unfortunately, the answer is no. You will still need to be in quarantine because that virus could reach a level where it's detectable, maybe not the day you got tested, but maybe 2 or 3 or 4 days after that.
That is so helpful because a lot of people are asking questions around, you know, if you're visiting grandparents or visiting grandchildren and vice versa. I would, you know, just answer that myself to say that that even visiting from state to state and even if you have a negative test, it's so important to practice that social distancing, wearing face covering, wearing a mask, wonderful hand hygiene, and staying that physical distance apart, because having a negative test and feeling like, well, I'm negative, so I can go into my house, be around my grandchildren, or they're negative and they can be around me, it's just too much risk to put it on testing.
Lois, I want to just comment on that really quickly. It's a really critical point. The approach to COVID-19 does not turn upon any one strategy. And we get a lot of questions for people who say, well, I saw on Twitter that you can be negative on Monday and positive on Tuesday. So what's the use of this entire testing thing that you make people do? It seems silly to me. Or I saw on Twitter that you can have COVID-19 and not have a fever. Or I saw this, or I saw that. What I think is important and really critical is that the approach to any crisis, it doesn't matter whether it's COVID-19 or the aftermath of a hurricane, is not dependent on one singular strategy. The approach to a crisis situation is to have multiple strategies in progress, working in parallel at any one time. It's like multiple layers of an onion that are all there to provide protection. You have a multi-layered approach to any situation. It would be like saying, you know what, I don't need to worry about anything in my house because I've got a lock on the front door. So I don't need to lock the back door. I don't need to lock down the windows. I don't need a security system because I got a lock on the front door. No one would say that. We all know for our own personal security, we take a multi-layered approach. It's the same thing with COVID-19. It's not just one strategy.
Thank you. And Dr. Bowe, can you talk to us about our local testing options and availability and how that works and how people can receive tests here locally if they're either symptomatic or not symptomatic?
Absolutely. Thanks, Lois. We are fortunate to have our testing site available and up. We have testing tents and a drive-through testing center at our Parkview campus. And if you have a physician in our system, the physician can order the test. If you had an exposure or you have symptoms, they can order the test. You'd call the testing center, they'd schedule a time, and you drive through and we obtain your test and then notify you as soon as we have the results. And we've been fortunate to be able to partner with the state swab and send program that you may have heard of. This is an opportunity to help us get tests for people who don't have a physician or a provider in the area. So if you don't have a provider, there is a state standing order that can be used to obtain a test. And again, if you just call our call center, then we're able to have a person come straight through, get a test scheduled, get the test obtained, and then we send it to the state and then notify the person of the results. So we do have options for everyone to get tests when tests are indicated. We're really happy to be in that spot and glad to be able to partner with the state on that swab and send program.
And can you explain how the safety measures that the hospital is taking to ensure that people who are coming for their care, that it's safe for them to receive routine care so that they're not putting off, and maybe talk about the issues around the mortality and morbidity that increases with putting off needed health care?
Yeah. To build on Dr. Shah's point, it was such an excellent point that I love the onion analogy of safety. And that's exactly what we've been implementing throughout our facilities to both keep any patient safe when you come into a facility, if you come to see our primary care physicians, or if you come into the hospital for acute care needs, we have that onion approach of we screen everyone for symptoms. We have everyone wearing masks. We are very careful about hand hygiene. We screen our staff as well as any visitors who come in. So we're taking that multi-layered approach to try to make sure that people are safe when they come for care. And what we did see early on, particularly March and April, was the need for people to hunker down at home, to shelter in place, and that was an early response. And of course, people delayed some of their needed primary care, some of their needed screening tests, and that was the right thing to do early on. We now are reaching a point where we want to make sure people aren't avoiding care that may detect or identify an illness or a disease process that we could treat, and that we can treat better if we identify early. So things such as a screening colonoscopy that a patient may be due for, it's really important to be able to get those tests, detect any abnormality, and treat it early before it becomes a bigger problem. And we're fortunately in a position where we're able to do that safely. So we do want patients to reach out to their physicians, their providers throughout our system or whatever system you go to for care, to make certain that you are up to date on your screening tests and your regular vaccinations and everything else to keep your health safe. Avoiding healthcare because of fear of COVID becomes a danger in and of itself as well.
Thank you so much, Dr. Bowe. And the phone line, the call center for COVID testing and all kinds of, any question around COVID is 373-6699. You can also find that on our website, 373-6699. That's where testing is scheduled, and they can answer questions. Dr. Shah, there's so many concerns about as our children are back in school and how we are ways that we can communicate the risk of COVID-19 to youth without scaring them, while also conveying the seriousness of this virus. And any advice that you have about parents with young children who are navigating this really challenging time right now of having their children in school?
Oh, boy, what a great question, Lois. What a really, really great question. My team and I have been thinking about this exact question because it's important for kids to know why it is that they've got to wear a mask in school and why school looks a lot different this year than it did last year. So I want to be completely candid with everybody. I am by no means an expert whatsoever on communicating risk to children. That is an art that pediatricians have mastered over the years, and one that I consider myself to be still a novice at. But the approach that I've taken and that I've seen counterparts of mine across the country to take is clearly it depends on the age of the child. But to talk about COVID-19 as a new thing that has arrived in the same way that they might talk about any new thing, whether it was on the horizon, be it a hurricane or a wildfire, which sadly our country is grappling with both right now. And to be straight with kids about what it is that is concerning, why the changes that are in place are happening, but then couple that with reassurance that because of those changes, because of the work that's being done, that things will be okay. That the world will not be in the way that it is now, but for the time being, there are hard things that we all have to do in order to keep everybody safe. I think that's the strategy I've observed counterparts of mine in other states using with great success, and it's the way that I've tried to communicate the same here in Maine. There's not an easy parable or metaphor that makes COVID-19 relatable to kids in the way that one can do with ourselves. I think talking about what it is, why it's concerning, why things look different, but that reassurance that eventually we'll be on the other side of this, that's the right strategy.
Thank you so much. And there's another great question. We have so many questions and so little time. It's wanted to have, there's a suggestion that what should someone living alone have at home for future needs should that person, if they have begin to develop symptoms of COVID, and I know that would be something that we could also, we will put something like that on our website so that people can turn to that to get that answer, but do you have any quick suggestions for what should people do if they begin to get symptoms of COVID?
It's exactly what Dr. Bowe mentioned. So the best thing you can have if you are someone who lives on your own, the best thing that you can have, one of your best allies here, is a great relationship with a primary care doctor. That's something that if you haven't had up until now, I'd urge everyone to take a little bit of time as we go into the fall. We talk about flu seasons as we get ready for COVID vaccines, and we talk about folks who might start showing symptoms. That relationship with a primary care provider is one of the best and most essential tools that you've got. Because if you start getting sick and you're not getting better and you have 102 or 103 fever, that's someone you can call. And then through the process that Dr. Bowe mentioned, you can get tested, not just for COVID-19 initially, but for other things as well that we know that may be circulating in the winter. So the one piece of advice I'd have is to shore up that relationship or foster that relationship with a trusted primary care provider.
Excellent. Thank you so much. And as we wrap up our time together this morning, again, Dr. Shah, I just want you to know that that especially since the beginning of this, we just have all turned to you as a source of truth and guidance that has meant so much to us as healthcare providers and the public. And we're so grateful for your dedication to public service and public health. And to let our viewers and folks that are listening in this morning know that we here in your local healthcare community are prepared for taking care of patients with COVID. There was another question of how many patients we have had here. We didn't even get a chance to talk about that, but we've taken care of dozens of inpatients and many more outpatients with this disease, that this is a safe place to receive the care, that all the safety protocols are making a difference. We've not had any transmissions here to patients or staff. If everyone will knock on wood and say thank you. We just have been very fortunate that the early strategies around universal masking and physical distancing and hand hygiene are so important. And if there's one thing that you can all do to help your community and help your healthcare system, it's to continue to fulfill those basic things of the peeling of the onion, of locking the front door and the back door, of wearing your mask and washing your hands and staying physically distant. I'd just like to thank the Maine CDC and all of our community partners for support. I encourage you to call either 211 or visit the Maine CDC website or Mid Coast Hospital's COVID resource page, because there's probably no question you can't get answered with looking at these resource pages as well. And also to just thank Deb and the BDA and the volunteers who put this program together today. Deb?
Thank you, Lois. On behalf of the Brunswick Downtown Association, I would like to thank our panelists, Dr. Nirav Shah, Dr. Christopher Bowe, and Lois Skillings. The information that you've provided for us today is so valuable as we maneuver our way through this pandemic and try to get on with our lives. Another shout out to the sponsors, Mid Coast Parkview Health, Atlantic Federal Credit Union, Sunnybrook, Avita of Brunswick, Riley Insurance, and Bowdoin College. And please consider a donation to the Brunswick Downtown Association by clicking on the Support BDA button on our website, brunswickdowntown.org. Thank you again for all who participated. Have a great day.
Thank you. Bye.
Thank you.
Thank you, everyone.
Bye.